Welcome to this video on approaching abdominal CT scans in the emergency department, designed to help emergency medicine residents recognize high-risk, life-threatening findings. Our learning objectives are to master a systematic reading approach, identify critical killer findings, distinguish between similar-looking conditions, and apply the correct contrast strategy for acute abdominal cases. In the ED, your initial pass through the CT images is often what activates urgent care, like surgery or interventional radiology, long before the final radiologist report is available. Follow this systematic four-step approach for every scan. Check the vasculature, examine solid organs, evaluate the bowel, and finish with a lung window pass to catch subtle, life-threatening findings. When considering technique, IV contrast is the default for most acute abdominal pain. Oral contrast is often skipped to save time, and for hemodynamically unstable patients, do not delay imaging for contrast phases. Always start by assessing the vasculature. Identifying aortic rupture or ischemia early is critical, as these conditions require immediate intervention. For AAA, a widened, calcified aorta with adjacent hematoma is diagnostic, even on a non-contrast scan. If you see this in a hypotensive patient, activate surgical support immediately. Regarding mesenteric ischemia, watch for a loss of bowel enhancement or pneumatosis intestinalis. These are late signs of necrosis, and patients exhibiting them need an emergency surgical consult. Distinguish between portal venous gas, which is ominous and suggests ischemia, and pneumobilia, which usually follows biliary procedures and is often benign. Location is key. Moving to solid organs, perfusion is vital. When evaluating trauma to the liver, spleen, or kidneys, the primary goal is to identify if active bleeding is present. For solid organ trauma, contrast is required. Look for a contrast blush, which indicates active extravasation. This finding often dictates whether a patient requires immediate IR embolization or surgery. Diabetic patients are at higher risk for emphysematous infections. Identifying the location of gas within these organs is essential for determining the necessary level of aggression in treatment. Emphysematous cholecystitis is a surgical emergency. If you see gas within the gallbladder wall or lumen in an at-risk patient, move toward emergent cholecystectomy rather than standard elective pathways. Similarly, distinguish between emphysematous pyelonephritis, which involves the parenchyma and is highly lethal, and emphysematous pyelitis, which is confined to the collecting system and generally requires urgent rather than emergent intervention. Finally, remember that conditions like free air, closed-loop obstruction, and soft tissue infections are time-sensitive. Rely on your systematic review to identify these risks and consult your surgeons promptly. Now let's examine signs of a perforated viscus. Pneumoperitoneum is the classic sign. Use your lung window pass to spot even small volumes of free air, as CT is much more sensitive than an upright plain film. When identifying a perforation, look for the source by searching for focal inflammatory fat stranding. Remember, free intraperitoneal air is a surgical abdomen. Keep the patient NPO and involve surgery immediately. A closed-loop bowel obstruction occurs when a segment is obstructed at two adjacent points. Watch for a C-shaped or coffee bean loop with dilated, fluid-filled bowel, often with a twisted mesentery at its base. Unlike a simple small bowel obstruction, a closed-loop configuration carries a high risk of strangulation. It is a surgical emergency and cannot be managed with conservative therapy, regardless of how stable the patient appears. For Fournier's gangrene, look for gas tracking through the perineum or perianal tissues. This is a necrotizing fasciitis emergency, and imaging is critical to reveal the true extent of spread before it's clinically apparent. In cases of suspected Fournier's, every hour counts for patient survival. If you identify extensive perineal gas, call the surgical team immediately, even while the patient is still on the scanner table. Not every finding is a killer, but naming them correctly is essential. Recognizing common patterns like acute cholecystitis or an obstructed kidney speeds up diagnosis and helps you avoid unnecessary escalations. For cholecystitis, look for the tensile gallbladder fundus sign. For pyelonephritis or an obstructed kidney, look for the candy-striped nephrogram, where alternating bands of perfusion indicate localized inflammation or obstruction. Finally, identify epiploic appendigitis by the target sign, focal stranding around a hyperdense dot, which is self-limiting. Conversely, distinguish between cecal and sigmoid volvulus using the coffee bean sign to guide surgery.